So I guess for a little background, just because I'm bored, the big issue that a lot of people know with the long COVID definition is that it encapsulates 200 different symptoms. So people are like, well, it just gets overwhelming for a lot of medical professionals because they're like, well, it could be anything. It could be long COVID. It could be one of the many numerous umbrella conditions. And some of the things that people have started to do is they've started to bucket it into like 4 different things. Like in a recent one I showed on children, it's like you have your chronic persistent conditions. So you get your acute infection, something like a cough might never go away after that acute infection. So that's like one version of long COVID. You could have an exacerbation of old symptoms. So that would be like if you have asthma, then you get COVID infection, and then your long COVID is technically like worse asthma. So like you have chronic trouble breathing. So that's another way that it could be presenting. You could have completely new conditions that pop up, such as an autoimmune condition or like type 1 diabetes. So that's another thing. So new condition. Or the fourth one is like something they're doing like multi-inflammatory syndrome in children. This is specific for children, but like that's like a fourth category, like a really, really big problem that's a result of that COVID infection. So that's sort of like the 4 buckets I've typically seen. Extreme tickle in throat that last week's then goes away, then comes back, I cough really bad. Yeah, and stuff like that. So that would be like a chronic persistent type of symptom that could be classified on long COVID. So that's the sort of umbrella type thing that I've started to see become implemented. But I would also like to see, like, and some papers have done this, is they start to bucket it. So like they have like an endocrine-based long COVID, they have a pulmonary-based long COVID, so like your hormones, your lungs. There could be vascular-based long COVID, there could be brain-based long COVID, there could be I'm forgetting like an obvious one, but like those types of things. I don't know where to go for help, if that's help. If there's help. Yeah, and that's sort of the problem, is like when you have such an umbrella term, it's like how do you start to push people in the right direction? And that's sort of like why there's the need for this conference for exactly your case. And that's what I'm hoping that they're going to address in this, is because I've seen like 2 different approaches, and I think both are probably needed, and to show people that there are different types of ways that long COVID can develops, because I think a lot of people have long COVID, they just don't recognize it, especially with people that had like something like asthma, like a pre-existing condition that got worse. Like that's still technically long COVID, because it's a viral exacerbation of your symptoms. I think the number is much higher. Will you upload this to YouTube later? Yeah. I'll for sure I'll upload it to YouTube later, because TikTok will send me a little. Sorry, I had a secondary alarm, so this is 10 a.m. now. Yeah, I'll upload it to YouTube as a full video for people to watch. So that's sort of the issue that is at hand, and why it's important to have a definition. The issues when you start to define things, if they start to like say, all right, we're only going to focus on like 40 symptoms, if they go that way, which I would not like, then it becomes an issue of like, all right, what about the other 160 symptoms? Because then those things wouldn't be covered by insurance. That's the big issue after like figuring out where to send people, is like, how is it going to be covered by insurance? If we bucket it down, like that was a big thing with the AIDS crisis, is that they bucketed it down into certain symptoms, and when people had those other symptoms, it wasn't covered under insurance, and then you can't get the care, or the care is incredibly expensive. So that's where the definition becomes very important. It seems like a semantics thing, but it becomes very important specifically for insurance purposes. Here we go.
My name is Megan Lowry. I am the manager
I'll turn it up.
of Media Relations for the National Academies of Sciences, Engineering, and Medicine. Thank you very much for joining us today for this webinar on the report that was just released this morning, titled A Long COVID Definition, a Chronic Systemic Disease State with Profound Consequences. You can now download a copy of the report and other supporting materials at nap.nationalacademies.org, and a recording of this webinar will be available on our website in the coming weeks. For those of you who are not familiar with the U.S. National Academies of Sciences, Engineering, and Medicine, We are private, nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, engineering, and medicine. For each requested study, panel members are chosen for their expertise and experience, and they serve pro bono to carry out the study statement of task. The reports that result from the study represent the consensus view of the entire committee, and they must undergo external peer review before they are released, as did this report. Before I introduce a few members of the committee that are joining us today, I'll just go over a few reminders. Please note that this webinar is scheduled to last 1 hour, so we'll start off with a presentation summarizing the report from the committee, and then we'll open it up to any questions you may have. And to ask a question, just type it into the box below the video player labeled Slido. You can submit a question anytime during the presentation, and I'll note that we are not able to offer medical advice or respond to questions about individual medical cases during the Q&A. So now I'll introduce the members of the committee that wrote the report who are here with us today. We have Harvey Feinberg, Chair of the Committee and President of the Gordon and Betty Moore Foundation. Karen Bischoff, Founder and President of the COVID-19 Long Hauler Advocacy Project. Lily Chu, Vice President, International Association for Chronic Fatigue Syndrome and Myalgic Encephalomyelitis. Abigail Dumas, Assistant Professor, Department of Women's and Gender Studies at the University of Michigan. Wes Ely, Physician Scientist and Tenured Professor of Medicine and Critical Care, Vanderbilt University, and Associate Director of Aging Research, Tennessee Valley VA Geriatric Research Education Clinical Center. Jerry Krishnan, Professor and Associate Vice Chancellor, Population Health Sciences at the University of Illinois Chicago. And Caitlin Pedati, Public Health District Director of the Virginia Beach Department of Public Health. And with that, I will turn it over to Harvey Feinberg.
Megan, thank you so very much for your kind introduction and for all your help in arranging this public webinar. On behalf of the committee and our staff, it's my privilege to be able to present the results of our effort to define long COVID. Our report is entitled A Long COVID Definition, a Chronic Systemic Disease State with Profound Consequences. Today, the agenda will cover the following items. First, we'll provide a brief background on what we were asked as a committee to do. We'll overview the methods that we use and then proceed to summarize the definition that our committee puts forward. After that, we'll review some of the key considerations that went into the definition of long COVID, some of the considerations, especially around using the definition, putting it into practice. And finally, I will briefly summarize the key recommendations from the committee and make a few concluding remarks before turning then to members of the committee who were just introduced for their comments, following which we will take questions as time permits. The study that we'll be presenting was requested of the National Academies by the Administration for Strategic Preparedness and Response and the Office of the Assistant Secretary of Health in the Department of Health and Human Services. The reasons that they asked us to undertake this effort is beginning with the reality that ever since the COVID pandemic began, millions of individuals have experienced ongoing symptoms. These long-term effects, known as long COVID, can be profound. And despite the fact that there have been many efforts to characterize this condition and many different definitions put forward, today there has not yet been a common definition that has been widely agreed upon. Part of the problem is the heterogeneity of the condition itself, which is reflected in the heterogeneity of the definitions. But the lack of a considered uniform definition that's widely accepted hampers individual patients' ability to get the care they need. It hampers research, surveillance, and the availability of support for patients who have this condition. The charge to our committee was very straightforward. Take account of all that is known today, ask carefully what individuals experiencing the condition need, consult with experts, and put forward a thoughtful, considered definition of long COVID. The committee itself is made up of 16 individuals drawn from literally hundreds of candidates reviewed by the national academies. These individuals represent a spectrum of backgrounds and experiences that were brought to bear on the task at hand. Experts in clinical care, in the natural sciences and virology, in the social sciences, in the experience of long COVID itself, and in public health. In addition, a number of the members of the committee, with whatever other expertise they brought, also were individuals who had experienced and are experiencing long COVID. The report that we'll cover has 7 components. First, there's an introduction that describes the background, much as I'm currently covering. We then go directly into the definition itself, and we'll be covering that in just a few minutes. We summarize the evidence and the key elements that provide the background for the definition. We provide application examples in clinical care, in research, and in public health surveillance where the definition may be deployed. We discuss the various elements of the definition and explain why it will need to be updated as new science and understanding come forward about long COVID. We describe the limitations of the definition, which are really the limitations of science today about long COVID. And finally, the report concludes with 3 core recommendations that I will summarize in good time. The process that the committee pursued is summarized on this slide. We had an initial scoping phase of the project under the aegis of the National Academies Standing Committee on Emerging Infectious Diseases and 21st Century Health Threats. We spent the better portion of last year in an intensive series of efforts to reach out to stakeholders, to experts of various kinds, and most prominently to individuals who had themselves experienced or were experiencing long COVID. These engagements included workshops, surveys, focus groups, and open fora for feedback and input to the work of the committee. The committee took account of this as well as the literature on long COVID and current scientific efforts related to long COVID to craft what we believe is a good definition as of this year to use in understanding long COVID. I want to emphasize, as indicated on the next slide, that throughout this process, the committee had foremost in mind the needs and impact of this condition on individual patients and their families. As one participant reminded us, patients need to be able to understand it and see themselves in the definition, because they may need to advocate for themselves or their loved ones for initial care or continued care or recognition. The committee did look at many different ways definitions can be deployed for health and even more broadly. Indeed, there is really no standardized guidance on what constitutes a good way to develop a definition of disease. And early on, the committee articulated a number of different features and criteria that could become useful elements in the course of our deliberations. And we had these, as listed on the right side of this slide, in mind as we proceeded in our deliberations about the definition. I want to stress terminology for a moment because we came to recognize that using consistent terminology is as important as using a consistent definition. Among the key terms that the committee utilized and promotes in the course of our definition, first, long COVID itself. This is a patient-developed term. It's simple. It's familiar. It can facilitate communication with family members and with caregivers, with the scientific community at large, and with the public. There are many other terms, some sounding more technical, certainly more complicated, that can apply to the same condition, but our committee chose to go with what is simple, familiar, and equally applicable to any of the others to understand and define long COVID. Secondly, our committee adopted the term infection-associated chronic condition, a term that applies to a variety of chronic conditions that can be triggered by a range of infectious organisms, viruses, bacteria, fungi, parasites. This term indicates how long COVID fits within a larger family of infection-associated chronic conditions. And this term does not carry with it any unwarranted implications about specific pathobiological mechanisms by which long COVID or other infection-associated chronic conditions may develop. And finally, we applied the term disease state to the experience of long COVID, and that was to stress the systemic reality and complexity of long COVID. Now let's turn to the definition itself, which is summarized on the next 3 slides, which each cover one of the 3 key parts of our definition. The first part is a statement that characterizes what long COVID is. Long COVID is an infection-associated chronic condition that occurs after SARS-CoV-2 infection and is present for at least 3 months as a continuous, relapsing and remitting or progressive disease state that affects one or more organ systems. Every word and phrase in this core definition has meaning and salience to understanding the meaning of long COVID. The second part of our definition characterizes how long COVID manifests or expresses itself either as single or multiple symptoms or as single or multiple diagnosable conditions. This enumeration of characteristic symptoms and of typical diagnosable conditions that are part of the picture of long COVID, we believe can facilitate understanding and recognition among family members and with health professionals and others about the experience of long COVID. And then the third part of our definition, as shown here, has 7 key features that are characteristic of long COVID. First, that long COVID can follow asymptomatic, mild, or severe SARS-CoV-2 infection, and that previous infection may have been recognized or unrecognized. Second, long COVID can be continuous from the time of acute infection, or it may be delayed in onset for weeks or months. Third, long COVID can affect anyone, children, adults, it doesn't matter prior health status, disability, socioeconomic status, age, sex, gender, sexual orientation, race, ethnicity, or geographic location. Anyone can be subject to long COVID.
That deserves a clap.
This does not mean that everyone is at equal risk, but it's a very important statement of equity that long COVID can affect anyone. Long COVID can exacerbate pre-existing health condition, or it can present as new conditions. Long COVID can be mild or it can be severe. It may resolve or it can persist for months or years. There currently is no biomarker that can definitively demonstrate the presence of long COVID. Long COVID can be diagnosed, indeed must be diagnosed, on clinical grounds. And finally, and very importantly, long COVID can impair individuals' ability to work, attend school, take care of family, and care for themselves. It can have a profound emotional and physical impact on patients and their families and caregivers. These three components, the core statement, the expression of symptoms and diagnosable conditions, and the important features, are summarized on an infographic that appears in the report and is shown here on this slide, in a single visual attempting to apprehend the full range of the definition of long COVID. The disease state of long COVID, an infection-associated chronic condition initiated by SARS-CoV-2 acute infection, expressed as common symptoms and or diagnosable conditions, and with the important features that I just recently summarized. Now,
He's getting a call.
apologies for that interruption. Now, let me go on to some key considerations for this definition. First, the committee strove to put forward a definition that would have a number of qualities: precision, feasibility, acceptability, accessibility, one that would balance benefits and harms, one that recognized the impact on health equity, and that understood unintended consequences. Very importantly, the committee grappled with the balance between attempting to include all patients who experience long COVID while avoiding wrongly including patients whose condition is not related to the prior SARS-CoV-2 infection. This general dilemma of balancing false positive against false negative errors is a very common problem in any diagnosis. And the committee believes that the treating clinician is in the best position to strike the right balance between avoiding those two types of error. Let me just say a word about why and how this definition differs from some of the prior definitions that had been in use. First, to re-emphasize, this definition uses intentional terminology: long COVID, IACC for infection-associated chronic condition, and disease state. It introduces some new features that many other definitions lack. First, and importantly, it provides explicit examples of common symptoms and conditions characteristic of long COVID. Secondly, it does require a duration of 3 months or longer, not necessarily starting at the time of acute infection.
That's a really good
But
line.
extending from at least 3 months from the start of the symptomatology of long COVID before the definition should be fully applied. This does not mean that the patient's condition should not be attended to immediately as it presents, but these 3 months allow for other conditions to be separately diagnosed or resolution of symptoms that does not really constitute long COVID. And the committee's definition, we think importantly, has an explicit statement related to equity. There is no requirement in our definition for laboratory confirmation or other proof of the initial SARS-CoV-2 infection.
Another clap.
And indeed, given the reality that most likely 80 to 90% or more of the American public has experienced acute infection during the period of the pandemic, and that especially early on, clinical tests had a high false negative rate, the idea of depending on a positive test would actually create more errors than not in the diagnosis of long COVID. One of the important acknowledgement and limitations of the definition is that there is no current biomarker that would definitively define the presence of long COVID. And finally, our definition does put stress on the impact of long COVID on function, and we believe that's an important key feature among the others that we included. Now, let's go on to some of the ways this definition can be utilized. In the report, we cover three particular uses: clinical care, research, and public health surveillance. In each instance, we recognize that judgment needs to be exercised, that often subsets of patients who would otherwise qualify for the definition in general may be more suitable to a particular research project, for example, that might focus on only a certain subclass of symptoms or only a certain age group. And we also recognize that judgment needs to be applied at every level in utilizing this definition effectively. I might mention in this connection that a parallel report to ours, recently issued by the National Academies, specifically looks at long-term health effects of COVID-19 and its implications for Social Security, for disability judgments. And that indeed would represent a very important fourth use case in addition to clinical care, research, and public health. We believe that everyone involved in the care and support of patients with long COVID should be aware of the key features as represented in the definition. Now, let's just go on to the final recommendations of the committee, because we firmly understood that this definition will need to be updated as new science and understanding emerge about long COVID. Our core recommendations are three. First, adopt the definition, the terminology, and the definition. And we believe it has relevance and should be considered by all of the relevant public health authorities, clinical societies, clinicians, research organizations, employers, and others who deal with the problem of long COVID. Secondly, we recognize that in implementing, it is important also to monitor how well the definition works in practice, what problems emerge, how well it can be utilized both nationally, domestically, and in promoting understanding globally about the role and relevance of long COVID in the lives of patients. We believe this definition deserves wide dissemination and implementation. And finally, for emphasis, we believe in no more than 3 years, or as new science may emerge soon, that it would be worthwhile to re-examine and update the 2024 long COVID definition set forward in this National Academies report. Let me conclude my remarks simply by restating that we conducted our deliberations, and we present our report in the hope that it will be of genuine value to individuals who experience long COVID, who work with them as caregivers and family members, and all who are concerned with the care of individuals with long COVID. We believe that the approach we took, including so much engagement with our stakeholders and experts alike, reviewing the literature as extensively as we have the privilege to do, and deliberating openly and honestly with one another, produced a holistic and integrated approach to understanding this disease state. We hope that it will prove to be useful, most especially to those experiencing COVID, but to all who are concerned with it in society. With that, let me thank everyone for being here. I want to acknowledge especially the members of our staff, our director, Lisa Brown, who was so instrumental, and all staff who made this work possible. Now, if I may, I'd like to turn for their comments to the other members of our committee who are with us. Karen, let me begin with you and invite your comments, please.
Sure, thank you, Harvey. Good afternoon, everyone. My name is Karen Bischoff. I'm a person with long COVID and many of its associated conditions, such as POTS, lupus, mast cell activation syndrome, gastroparesis, chronic migraine, and several others since infection in March of 2020. I am the founder and president of the COVID-19 Long Hauler Advocacy Project and former firefighter, paramedic, and educator. In addition to my contributions to this committee, I serve as an external contributor to the AHRQ Long COVID Care Network, on the NIH Recovery Initiative's Ancillary Studies Committee, and as chair for the Long COVID Alliance on a project bringing together infection-associated chronic conditions communities. I am pleased with the definition our committee has put forward based on the review of 116 studies, engagement of over 1,300 patients and stakeholders, and a patient-centered, science-forward approach. Varying definitions, inconsistent terminology, lack of education, and access issues have delayed progress and hindered patient care. The 2024 NASEM long COVID definition aims to aid in consistent diagnosis and treatment, promote a holistic approach encouraging interdisciplinary collaboration, harmonize research, surveillance, and public health trends by supporting standardized data collection, raise awareness and educate stakeholders, enhancing patient access to care, and address equity considerations for all demographic groups. To accomplish the aforementioned aims of this definition and advance our understanding of and solutions to long COVID, there needs to be universal uptake and usage of the definition to be able to standardize the data. Adoption and implementation by all stakeholders is essential. As a committee member, long COVID organization lead, and person with long COVID, I personally stress and reiterate the findings from our engagement process that indicated the need to pair a new definition with a dissemination and education campaign to inform the public and key stakeholders combating the systemic issues embedded within long COVID. For years, long COVID patients and caregivers have faced bias, stigma, and misinformation, with clinicians often unaware or unwilling to learn about the condition, especially in the absence of a singular definition and consensus guidance. This definition helps overcome existing barriers and destigmatizes long COVID by presenting current information backed by vigorous scientific review and committee deliberations. It validates the experiences of millions and educates all stakeholders, including patients, caregivers, the public, clinicians, and researchers, policymakers, health agencies, and stakeholders in social safety net programs, such as payers, employers, academic institutes, and support services. I would like to emphasize several key components that deserve highlighting and emphasis from the definition and report. Patient-centeredness was an instrumental part of this process, and long COVID patient-developed terminology was prioritized, such as making long COVID the formal name over several others that have previously been used, as well as the term infection-associated chronic conditions and the use of describing long COVID as a disease state. The definition applies to both adults and children, which was widely recommended during the committee's engagement process, regardless of health, disability, or socioeconomic status, age, gender, sex, or sexual orientation, race, ethnicity, or geographic location, recognizing that social determinants of health and structural inequities intersect to create health disparities. The definition does not require a positive test because no test has perfect sensitivity and because the rates of false negatives on antigen and PCR tests vary with time and other factors. As a patient advocate, I also emphasize that the rate of current testing lacks given messaging that downplays the severity of COVID-19 and the same issues that existed early in the pandemic related to testing access and surveillance is still very much an issue now due to the lack of testing participation. Additionally, equity plays a significant role in a person's access to acute COVID testing, access to evaluation for long COVID, willingness of clinicians to diagnose a particular patient, and access to insurance benefits and patients' fears of stigmatization. The definition specifies a minimum duration of 3 months, whether consistent or relapsing and remitting, to qualify as long COVID. However, a clinician should recognize, acknowledge, treat, and monitor concerning symptoms before the 3-month mark and still document ICD-10 U09. Acknowledge, treat, and monitor concerning symptoms before the 3-month highlights. There may be several mechanisms involved in long COVID, such as immune dysregulation. There may be several mechanisms involved in long COVID, such as immune dysregulation, autoimmunity and immune priming, viral persistence, blood clotting and endothelial abnormalities, dysfunctional neurological signaling, and microbiota dysbiosis. The definition does include POTS and ME/CFS, among others, as examples of diagnosable conditions that can be part of the picture of long COVID. These and other potentially overlapping conditions are compatible with the diagnosis of long COVID. For example, patients may be diagnosed with POTS and long COVID, or long COVID and new onset rheumatoid arthritis. Long COVID is an umbrella term that can be diagnosed alongside associated conditions. Long COVID is not a diagnosis of exclusion. Long COVID has significant medical, social, and economic impacts, and the definition firmly acknowledges the profound impact of long COVID on function and the ability of patients to work, attend school, take care of family, and themselves. It is essential for researchers to try to adhere to the definition as best as possible when choosing inclusion and exclusion criteria and strongly justify alterations so that the data remains meaningful and further contributes to our understanding of and solutions to long COVID. As a person with long COVID and many of its associated conditions, a community leader, and committee member, I strongly recommend adoption, implementation, and monitoring of the 2024 NASEM long COVID definition to standardize clinical management, research, and policy efforts. A uniform definition helps overcome many of the challenges currently faced in clinical care, research, public health surveillance, current and future pandemic response, and overall helps improve patient outcomes. Thank you.
Thank you very much, Karen. Let me turn now to Lily for your comment, please.
Thank you, Harvey. My name is Lily Chu, and I'm the Vice President for the International Association for Chronic Fatigue Syndrome and Myalgic Encephalomyelitis. During our engagement activities, the public told us that the number one way they would use any long COVID definition would be to explain their condition to other people. At the same time, recent surveys show that a third of Americans still are not sure what long COVID is. I believe that our inclusive definition will help both these groups. For example, someone who has never had a positive COVID test but experiences recurrent symptoms can now receive a diagnosis of long COVID. They can begin receiving appropriate care and support. Hopefully, family members, friends, educational institutions, and employers will understand patients' limitations better. By researching everyone affected by long COVID, and not just people with a positive test, researchers might make new discoveries. Our definition highlights some conditions that commonly coexist with long COVID, such as myalgic encephalomyelitis, chronic fatigue syndrome, postural orthostatic tachycardia syndrome, and migraine headaches. Each of these conditions has specific treatment and management techniques. By identifying them, clinicians can improve the function, quality of life, and health of patients. Finally, this project was challenging. There were many parts of the definition where we wish we could have been more specific. But to do so would be to create an illusion of certainty where there isn't any yet. A decade ago, I was a member of the NASEM committee that created the MECFS diagnostic criteria. Because we stuck to the evidence at that time, that definition remains true and useful. Similarly, for this definition, we relied upon the latest scientific, clinical, and experiential data that we could gather now. In the report, we do list areas that, if clarified, could improve the definition in the future. I am hopeful that researchers will provide us with answers soon. Thank you for your attention. Harvey?
Thank you, Lily. Let me invite Abby, if you would, to offer your comment, please.
Thank you, Harvey. Hi, all. It's great to be here with you. My name is Abby Dumas, and I'm a medical anthropologist here at the University of Michigan. I work on complex chronic conditions, and my first book was on the controversy over how to diagnose and treat Lyme disease. From a social scientific perspective, this definition, and maybe even more importantly, the process by which it was created, I believe really has the potential to make important contributions to both patient experience and health equity, as Karen spoke to us about. Like other patients with complex chronic conditions that present with a range of symptoms in the absence of definitive biomarkers, long COVID patients often suffer from the burden, the double burden of both feeling unwell and unseen in clinical spaces. So to better ensure that long COVID patients feel more seen, our definition process incorporated patient experience and knowledge from start to finish. That included committee membership to stakeholder engagement, as we heard about, up to external review. Linked to this was careful attention to terminology, as we heard, including the term long COVID, which was coined by patients, but also infection associated chronic conditions and disease state. And because patients with complex chronic conditions can be stigmatized and marginalized through language, this careful and consistent attention to terminology is really a key feature of the 2024 NASEM long COVID definition. The definition, as we heard, was deliberately inclusive, and this is to ensure that as much as possible, the range of ways that long COVID can be experienced and lived is captured. And along these lines, our findings from the stakeholder engagement process really reinforce the urgency of being attentive to health equity. So important to note here that the definition is currently the only definition that references equity. Thanks so much.
Thank you very much, Abby. Wes, let's go over to you, if I may.
Thank you so much, everyone. And it's a pleasure to be here with you all. My name is Wes Ely, and I am a pulmonologist and a critical care doctor and an internist at Vanderbilt University in Nashville, Tennessee. We have a busy long COVID clinic here at the university, and in addition, we have a research center that has created a space for a community for long COVID patients and families and loved ones. And every day of the week for the past several years, we've had support groups for anywhere between 30 and 50 patients who are suffering from long COVID, or caregivers who are doing their best to understand how long COVID is affecting their loved one. Through these support groups and through the clinical interactions, I've just found an intense amount of frustration on the part of those suffering this disease state. And I was just going to share with you two anecdotes of how I think that this long COVID definition and this work that the committee has done for NAM might be able to pay it forward back into both individual lives and society at large. One woman example I was going to give you, and I have permission to use these examples, but I will not share any identifiers, one woman was trying to get disability and having to go through some form of a court system. I won't mention the states, and I'm deliberately being a bit vague on this because I don't want to give away any identifiers. It's not relevant. But she'd gone all the way through physicians and advisors and gotten the right letters, etc. And a judge threw it out and said that they didn't think that she had long COVID, and that person was super frustrated about her inability to get financial support for her life, which was kind of falling apart. And the second story I'm going to read to you is just an email I got this past week, and it's from another woman who was trying to apply for Social Security disability and unable to get it. She came to see us in our clinic. We absolutely confirmed a diagnosis of long COVID that met the definition of our NAM committee, and she writes, "I just received word I was denied disability for the third time. Even with a letter that you graciously wrote for me, how can I be denied? There is a long COVID disability under the ADA, Section 504 and Section 1557. I surpass every symptom. I cannot begin to put into words how frustrated and sad I am and confused. I'm suffering physically, mentally, financially. My marriage is over because of this thing called long COVID. Someone please help me." I believe that what we have done in our NAM committee is create an evidence-based definition which meets the societal and individual needs of others, and which we will be able to use in the clinical and research setting moving forward. I'll close by saying that we're about to start here at Vanderbilt as the lead site a large phase 3 trial of immunomodulation in long COVID. And I am so excited about putting out this report for long COVID because I believe it will legitimize lots of different investigators' ability to design different studies around this disease state. I'll end there, and thank you so much for your attention and time today. Harvey?
Thank you, Wes. Jerry, we're over to you.
Thank you so much, Dr. Feinberg, and really appreciate the time to speak to everyone. Just by way of introduction, my name is Jerry Krishnan. I'm also an adult pulmonary critical care physician. I'm a physician scientist. Also serve in the role of the member of the executive leadership team for our health system at the University of Illinois in Chicago. I founded and direct also the adult pulmonary post-COVID clinic for our health system. As a researcher, I really focused during the pandemic on acute COVID trials, and now I serve as the overall principal investigator for the Illinois Research Network, part of the NIH Recovery Initiative. And finally, was invited by the Agency for Healthcare Research and Quality to serve on this long COVID care network as an external contributor. So multiple roles as a physician, as an administrator, as a researcher, and as a contributor to any number of efforts on the federal side as it relates to long COVID. I wanted to add my perspective from a research perspective, ultimately wanted to, again, appreciate the work of this committee and add my support by saying that the 2024 NASEM long COVID definition is by design inclusive and overarching with many possible areas of use case, if you will. And this will, from the research perspective, and there is an enormous need to understand how to control this condition and disease, that this will allow researchers like me and Dr. Ely and others the flexibility that is needed in designing studies while also staying consistent with the definition, if you will. So for example, studies may be designed to answer questions like what are the harms and benefits of treatment X in patients with shortness of breath associated with long COVID, or what is the symptom trajectory of patients who develop long COVID after the age of 65. In both these specific research applications, we could very well use the long COVID definition that is now being promulgated by the National Academies. The 2024 National Academies of Science, Engineering, and Medicine definition will therefore need adaptation or selective application as it is applied for research so that it can be fit for purpose, but it does provide the mechanisms to do that. The committee specifically encourages investigators to explain the rationale where necessary for these adaptations and how the adaptations affect the interpretation and generalizability of findings. So in the implementation section, we provide some guidance about how the overall definition could be used in the research community. And for that, I'm very grateful and thankful for the National Academies. Thank you.
Thank you, Jerry. And Caitlin, over to you.
So much. So my name is Caitlin Padati, and I serve as a local health department director here in the city of Virginia Beach. And so the perspective that I have to offer is based on my experience as a pediatrician and as someone who's worked in governmental public health and epidemiology at a couple of different levels. And I think I would just echo what you've heard from others, the importance of having a consistent definition is going to be so valuable in helping us for our applied public health surveillance activities, which in turn help us better understand the burden of conditions like this and how we might work to better ultimately prevent people from even having to worry about infection-associated chronic conditions like long COVID. So I really look forward to the adoption, monitoring, and subsequent updates to this important definition as we continue to keep an eye on such a critical public health issue. Thank you, Dr. Feinberg.
Thank you, Caitlin. Megan, let's turn to you, if I may. Are there questions that have come in that you could pose for the committee?
Yes, we'll get started with Q&A. I'll just remind the audience quickly to ask a question, type it into the box below your video player. That is how you ask a question. Our first one is, please help me understand the implications of this definition. It sounds like anyone who has been infected with COVID-19 and then develops lupus has long COVID, not lupus. Is this correct?
Let me make a first comment and then invite others as well. One of the important points that several people have mentioned is that our definition is not an exclusive definition. It's not a definition by exclusion, so that other diagnosable conditions can and are part of the picture coterminous with the applicability of the definition of long COVID. And that's a very important and fundamental point, and one way in which the definition we're putting forward differs from others who...
So just as a quick aside, what he means by that is that having a lupus diagnosis does not mean you don't have long COVID. You can still diagnose the person with lupus, just because, if you say they have long COVID, it doesn't mean that they can't get a lupus diagnosis. They're saying that because it's a new symptom that occurs, the lupus symptom that's popped up that's new after the COVID infection, that would meet the criteria for long COVID, is what he's trying to say. He's just not saying it very well.
Who have suggested that long COVID should only apply if other diagnosable conditions are excluded. Jerry, you have an additional comment, please.
Yes, thank you so much, Dr. Feinberg, and thank you for that question. It's an incredibly important and practical question. Our view is that someone can have long COVID and lupus, and I think, moreover, we, in the medical community and the patient community affected by these conditions, oftentimes struggle to understand why someone developed lupus, or why someone developed rheumatoid arthritis, or why someone might develop ME/CFS. And so I think by being inclusive, we are saying that you can have long COVID and lupus. This opens the door for us to do the kind of investigations necessary to understand the pathogenesis by which long COVID itself could trigger other illnesses, including conditions like lupus. We're not at this point indicating that there's a causal association, but we certainly see that in individuals in my clinic who come in with respiratory conditions after having had COVID, who then go on to also demonstrate autoimmune disorders, including lupus. So this now opens the door, inclusive definition, to do the kind of research necessary to move this forward. Taking all the conditions that are idiopathic, that we never quite understood what caused it, and now by including it within a series of infection-associated conditions, along with long COVID, do the necessary research. Thank you.
Great.
Megan, back over to you.
Our next question is, can you please explain the 3-month criteria again? It can be 3 months of symptoms or conditions at any point and not just from the start of the infection. Is there an endpoint to when this 3-month window should be considered?
Thank you for that question also, Megan. In the committee's deliberations, the 3 months can start at any point that the symptoms of long COVID begin to express themselves. Sometimes that follows directly on the acute infection, but sometimes there's a period of apparent recovery, and subsequently the symptoms of long COVID begin. The 3 months in our definition start when the symptom that is attributed to long COVID begins. And that, I hope, answers the question, but others may want to comment as well if there's additional clarification. Wes, you could.
Sure. For the committee to establish this as a 3-month set of symptoms for the diagnosis indicates that the literature shows that you can get a good balance of sensitivity and specificity when you have at least that much of an extended duration of symptomatology. If you shorten that duration to 6 weeks or 1 month, as one prominent definition prior to this definition had said, 1 month, you get very, very unspecific. You might get more sensitive, but very low specificity. So what we're trying to do here is get a higher area under the receiver operating characteristic curve, if you will, for our definition, a good balance of sensitivity and specificity. The main point is that we wanted as a committee to say to the world that the literature supports that if somebody really has this disease state, it doesn't go away that quickly. And 90 days is probably the minimum amount of time we want to be absolutely certain that somebody has this disease. Now, some of the comments earlier were said by some of our members with lived experience. That doesn't mean that a doctor at 1 month shouldn't be suspicious. Oh my gosh, you had COVID 6 weeks ago and now you've had a month's worth of symptoms. We need to start watching you because I'm worried that you're going to end up meeting the definition for long COVID, and we'll watch you carefully. I want to see you back again in 4 weeks and see how you're doing, and we'll start treating you. So the clinician has the leeway and the ability to use his or her gestalt to navigate this diagnosis, but
Essentially, it's semi-arbitrary, the designation for 3 months. They're just saying that, oh, we want to make sure that these symptoms are not going away within a reasonable long period of time, so they're picking 3 months. There really isn't a good reason to pick 3 months. It's just saying, all right, we see the symptoms and they're not going away. That means you definitely do have the disease now, is what they're trying to say, but he's just kind of making some stuff up.
90-day, 3-month symptomatology, I think, is critical. And the last comment I'll mention is that we didn't say that this clock ends, for example, a year after acute COVID or a year and a half after acute COVID. We didn't say that because the literature doesn't let us do that. But if somebody came in and they had COVID in 2020 and developed lupus in 2026, I doubt that any clinician is going to say, oh, I think this is long COVID. Whereas if they have COVID in 2023 and 6 months later they get lupus, that is extremely consistent with the disease state of long COVID.
Thank you, Wes. Megan, back over to you.
Great. Our next question is, how can patients and advocates best utilize the new definition to connect patients to adequate care, especially in rural areas where physicians lack incentives to investigate, provide care, or refer long patients for care?
That is a really challenging situation, and indeed it's not in any way limited to the long COVID. We're really talking here about the more generic availability and accessibility to proper clinical care for persons everywhere in the U.S., whether you're in a city or in a rural area. Jerry, would you want to comment on that?
Sure, thank you, Dr. Feinberg. And I would agree. I think this issue of access to care is a fundamental challenge that we face across all the conditions. And there are some areas that historically have had this disadvantaged positions, and I think rural areas are one good example of that unfortunate situation. I think by having a standard terminology, however, by saying long COVID, as separate from all the other words that have been used in the literature, we start to at least have some consistency by which we're naming the problem. Allow us to then connect individuals with that standard named problem, long COVID, with resources that are linked with that same condition. So this facilitates communication, I would say, number one. Number two, I think we need a broad educational campaign. And it's hard to have an educational campaign around something until we at least standardize the terminology that we're going to be using moving forward. So it is our deep hope that that the work that this committee has employed here begins the basis of standardized educational curricula with standardized terminology. And I think the long COVID definition, I think now starts to provide that. Thank you.
Thanks, Jerry. Lily, could you add your thoughts on this?
So a couple points. First, when people receive this definition, patients, families, you can bring this to your physician. A lot of times it takes months and even years for information to get to frontline providers. I used to practice primary care medicine, so that was my experience. And so by bringing it to your physician or other healthcare provider, you can educate them. There has been a change in the long COVID definition. A second, earlier I had mentioned that there are several diagnosable conditions. And so if you bring that and point that out to your doctor and ask them, do any of these definitions, could they apply to me? Your physician can begin treating because those conditions do have treatments linked to them. And then hopefully over time, they will read the definition in more detail. We have a full report, we have briefing materials, and they can learn more about long COVID.
Thank you, Lily. Megan, we're back over to you.
Great. Well, we have about 3 minutes left, so I'm going to guess that we probably have time for one more question. What are you most hoping that those experiencing long COVID take away from your report today? Are there any takeaways you want to leave them with?
That's a great question. Maybe we could ask each member of the committee who's here to just quickly offer what you would leave as the best or most important takeaway for you from the report. And I'm going to go in the opposite order, if I may, from the way we've normally done. And Caitlin, let me invite you first. What would be your takeaway message from the report?
That people can take away is that there's hope that we're going to continue to address this really important public health condition, and that while we may not know everything today, it doesn't mean that there's nothing we can do. And having this common language and consistent definition is a big step towards better understanding how we can treat and really ultimately prevent people from suffering from this condition.
Thank you, Caitlin. Jerry, what is your takeaway?
I think moving forward today, I would encourage the research community to adopt the phrase long COVID. And I think, again, from the purpose of simplicity, from standardization, for us to communicate that's necessary. So that will be my particular recommendation and my takeaway. Thank you.
Thank you, Jerry. Wes, what would be your...
Just for a quick background, so other ways that we describe long COVID currently is PASC, which is post-acute sequela of COVID. We have post-COVID conditions, which is an umbrella term like long COVID. And we have a few others, but just for examples.
One takeaway.
My one takeaway is that we hope that you, as the listener, the person experiencing long COVID or your family member experiencing it, hears us talking in this definition to say the following. You are the experts of your own illness. We're not the experts of your own illness. You are. And our definition has put together through, as Dr. Feinberg said earlier, over 1,000 people and hundreds of scientific papers to say, what is this disease state? And we put that into the definition so that it has heart, and the heart and soul of this is that you are the expert of your illness. And I hope this meets your needs going forward as somebody who wants to get the best care and relief from your suffering.
Thank you, Wes. Abby, what is your takeaway?
Thanks, Harvey. I think building on what's already been said and my previous comments, I hope more people feel seen in this definition. I hope that it works to bring patients, but also clinicians and researchers more on the same page, so that next steps have more clarity. Thank you.
Thank you, Abby. Lily, your takeaway.
My takeaway is that I hope this report validates the experiences of everyone affected by long COVID, and especially those people who did not have a positive COVID test. Because for the last 3 years, as I understand, they've had a very difficult time obtaining care, accommodations, support, because they didn't have that piece of paper saying they were positive. In our report, we talk about how there is a recent study, small study, that showed that about 40% of people who did not have a positive commercial test, in fact, had exposure to COVID on more specialized testing. And there are also some studies showing that the symptoms, prognosis, and trajectory of people who have positive and a negative test are not significantly different. So I really hope the study validates and validates their experiences.
Thank you, Lily. And Karen, back over to you for your takeaway.
I think the definition really highlights all of the available research to date and a patient-centered approach, and I think that it helps really end or cease the reasoning for a lot of stigma and bias that exists. And one of the most important things to move the long COVID community forward and our understanding and solutions to long COVID forward is having this consensus definition adopted and implemented so that we can begin to make sense of the data and really move our community forward. In my personal capacity and as a patient advocate, it's just as important for patients to help distribute this definition and report as it is for NASEM itself and for the government and clinicians. And if you are a clinician, I urge you to bring this to your facility, to your center, and to your bosses that make these decisions. And so my ultimate thanks are to this committee and to the community who participated, because without all of you, we wouldn't have been able to develop this definition. And I truly, truly feel that this definition is going to move our community forward.
Thank you, Karen. I will just say I hope that this definition will be of good use to everyone. And Megan, we want to thank you for your help in organizing the symposium, the webinar today. I will just take a moment to express my admiration and appreciation for all the members of the committee, and most especially the 6 who are with us today who shared their views directly in this presentation. And again, to thank our staff, Lisa, Taquam, all those who helped along the way to make this report possible. Thank you all for being with us, and we wish you all good health.
Thank you.
Cool.